Morning, I am covering a topic bleeding per rectum in children. I am a pediatric surgeon. I am head of the department at Wadia Children's Hospital, a consultant pediatric surgeon at Bombay Hospital, and also a joint secretary of Association of Medical Consultants. Now, where do these children bleed from? They can bleed from the upper gastrointestinal tract or from the lower gastrointestinal tract. The upper gastrointestinal tract includes the esophagus, the stomach, the first part of the duodenum, the second part of the duodenum, and the DJ, the duodenojejunal junction, up to the ligament of Treitz. So, anything below that. Now, if we include the entire small intestine in the upper GIT, because there are many causes which cause bleeding in the intestine, and all of it, the small intestine and the large intestine, have been included separately. So, when we talk of upper gastrointestinal tract, it includes the entire esophagus, stomach and the small intestine, and here today I have included the lower GIT as the colon, the entire colon, the rectum and the anus. There will be the different ways in which the patients will bleed. One, they would be having fresh bleed, as we call it hematochezia, as we can see in this picture, or they can have black colored, black tarry stools, which is called melena, or they can have occult bleeding, which means that visibly we cannot make out that the child is having any bleeding. Now, different causes give rise to different clinical scenarios. Let us just look at the causes of the common causes of bleeding per rectum. From the upper GI tract in newborns, red colored blood, which is hematochezia, is caused by volvulus of Midgut as the most common cause. Bacterial enteritis, drug induced enteritis or gastritis, congenital or acquired coagulopathies, hemorrhagic disease of the newborn or intussusception could also cause hematochezia. From the lower GIT, we do not ever get melena. If there is a lower GIT problem like anal fissure or arteriovenous malformation, then it is always bright red blood per rectum. The upper GI erosions and the peptic ulcer diseases cause black tarry stools. The amount of bleeding will decide as to how much is the stool color changed, whether it is just light brown or dark brown or it is pitch black and tarry. The reasons for bleeding in infants and toddlers up to 4 to 5 years of age are almost similar, except that these children can also have Meckel's diverticulum, benign hamartomas and tumors such as lymphomas or carcinoids, which could cause bleeding, and these, depending on the amount of blood which is lost due to the cause, the color of the stool will depend on that. From the lower GIT, as we can see, the most common cause is a rectal polyp, which we routinely come across in the outpatient department. Anal fissures, arteriovenous malformations, multiple colonic polyps in familial polyposis syndrome are other causes. The upper GI causes or the cause of black colored stools remain the same even in infants and toddlers. Is it different in older children? Not really, almost similar causes, except for that portal hypertension is one of the major causes of bleeding, whether it is red color blood, whether it is hematochezia or it is black tarry stools. It depends on the amount of bleeding. So, when we have a child with bleeding, quantification of the amount of blood loss is the most important thing. Whether there is a massive blood loss which requires evaluation, immediate evaluation and treatment of shock if present, control of bleeding and evaluation of the cause of bleed later. Moderate bleeding requires hospitalization immediately. rapid evaluation of the source of bleeding, and then control of bleed. Mild obviously can be treated on outpatient basis, where we can evaluate and treat the cause as per the source. So let us now look at what is the clinical presentation and how do we come to a diagnosis. Now if we have a child coming to us with blood mixed with stools, most often it is infective enteritis or colitis. It could be NEC in a neonate, it could be HUS, which is little rare, it could be eosinophilic enterocolitis, or it could be inflammatory bowel disease, not very common. If we have blood streaks in stools, the most common cause is anal fissure or rectal mucosal ulceration, and most of the times this is caused by constipation. If there is blood after the child passes stools and which drips after a normal stool, the most likely diagnosis is a rectal polyp. There could be vascular anomaly of the GIT, but that is little rare. If blood and mucus is mixed with stools, then it is most often infective, but intussusception must be ruled out because intussusception is a common cause. If there is frank blood, just blood, no stools, it is volvulus of the midgut, or it is arteriovenous malformations, or it is NEC, depending on the age of the patient and the amount of bleeding. If we do not see the bleed, but still there is a bleed, then it could be worm infestation, which is the most common cause. It could be acid peptic disease of the upper GI tract, which is common in children, though not picked up very often. It could be celiac disease, inflammatory bowel disease, or polyposis. So clinically, can we determine the severity of GI bleed? Yes, we can. The physical appearance of the child will tell us a lot. The presence of pallor, the hemodynamic status, that is the pulse, blood pressure, which will tell us the estimated volume of blood loss, and the color of lost blood also indicates how much is the bleed. If the color is bright red, which is obviously fresh blood, the amount of bleeding is definitely much more. If it is melena, it is a slow ooze and the blood changes color within the system, within the GIT, and that is when it is black in color. So look at the worrying signs, which are pallor, diaphoresis, restlessness, lethargy, and abdominal pain. Danger signals are orthostatic changes in the heart rate and the blood pressures, and these must be evaluated when the child is first seen. So look at the child, whether he is well or ill. Look at the vital parameters, whether the child is hemodynamically stable or not. Look at the abdomen is normal or it is distended, whether there is a lump palpable as in intussusception, whether there is tenderness anywhere. Look at the rectum, which means do upper rectal examination to find for anal fissure. There could be polyps which are felt, and look at the type of blood in the stools, which we have already discussed before. Can a child who comes with red or black colored stool be normal? Yes, there are substances that the children eat which can deceive us. Red discoloration could be caused by candy, fruit punch, jello, beets, watermelon, laxatives, phenytoin, medicines like rifampicin, and black discoloration could be caused by bismuth, activated charcoal, iron, spinach, blueberries, and licorice. So what is the surgeon's role? Yes, this is a surgical disease and surgeon plays a major part. Many a times when we can't clinically establish the diagnosis, we need to do a sigmoidoscopy. If we find a polyp, the sigmoidoscopy snare is used to remove the polyp at the same time. If we find polyps in the colon somewhere, maybe multiple polyps, then a biopsy can be taken and the polyposis coli can be further on treated appropriately. If there is a vascular malformation, even that can be picked up. So surgeon plays a major role. Do not hesitate to contact the pediatric surgeon and will treat you. Thank you very much.